Dear colleagues, this is Phaco emulsification of a non-intumescent white cataract. Let me show the surgical steps. This is the main incision, 2.8 millimeter. This is one side port on the left side of the main incision. Now I am going to inject a big air bubble in the anterior chamber. Underneath this air bubble, I inject trypan blue dye 0.06%. After a few seconds, I wash the dye out with VSS. Enough staining occurs within 5 to 8 seconds. Now this is HPMC, hydroxypropyl methyl cellulose, injected into the anterior chamber. Now one more side port is made on the right side of the main incision, and now is the time to do capsulorhexis. Since this is a non-intumescent cataract, I have planned to do rhexis of adequate size at one attempt. This is an utrata forceps, and I am at equal distance from the margin of the pupil all around, and I get an adequate sized rhexis of about 5 or 5.25 millimeter. And now I do not do hydrodissection in this case. I am going to follow the techniques that has been taught to me by respected Dr. Narayan Bordolui. I respect him very much. This is how we can do no hydrophaco. This is the first job. The tip is buried into the substance of the nucleus. A firm hold is created and the nucleus is chopped. This is a 5 o'clock chop. The nucleus is chopped, and now this is the 3 o'clock chop. This free nuclear fragment is brought to the center of the antechamber and it is emulsified. Now this is 7 o'clock chop. This free nuclear fragment is emulsified and taken out. By this time the nucleus is rotating. Enough of fluid has gone to the periphery and hydrodissection has occurred naturally. Dr. Narayan Bordolui says this is natural hydrodissection, and rest of the surgery is just routine. Emulsify the fragments and take it out. This is the last fragment. While I emulsify the last fragment, I remove the chopper so that leakage from the side port stops. Posterior capsule goes backward towards the vitreous cavity. Now I inject HPMC and I have to remove the cortical matter. This is a 23 gauge Simcoe cannula. I depress the posterior leaf, remove some viscoelastic substance, and then start removing this cortical matter. So enough of cortex have come out. Now the superior portion, the cortical matter which is there superiorly from say 9 o'clock to 1 o'clock, this has to be removed. What I do is I take bimanual IA for this. bimanual irrigation aspiration, and I remove this. That's it. The cortical matter has been removed. Some amount of cortical matter is probably there at around 6 o'clock. It will probably come out later. Now I am going to implant a foldable intraocular lens, hydrophilic foldable intraocular lens under irrigating fluid. I'm not going to use viscoelastic substance for implanting the IOL in this case. This is the intraocular lens. This is going into the bag. The leading haptic has gone into the bag, and the trailing haptic is also placed in the bag. Now we can see that the leading haptic has stuck to the optic. So what I do is I tease this haptic and it gets separated from the optic. Now we can see that there's some cortex is there at 6 o'clock and it is protruding into the anterior chamber. Now I remove it. That's it. So the cortical matter has been removed, and now this is a bit of moxifloxacin. Now I hydrate the side ports, but the case is not yet over. There is lot of viscoelastic substance sticking to the corneal endothelium. I take a Simcoe cannula and fresh BSS directly from the bottle and flush it towards the corneal endothelium, and we could see that lot of viscoelastic substance got dislodged and came out. That's it. Now I am happy that all the viscoelastic substance has been removed, and going to conclude the case. We must be very meticulous in each step of surgery. The patient should not have any discomfort in the postoperative period. The patient should not have any pain, any raised intraocular pressure, and that's the aim. Hope this video will help you in your practice.